So
All right.
everybody be good. We're recording.
Okay. Well, I just want to take a minute and welcome everybody. My name is Britt Anderson. I'm the president of the Minnesota Lyme Association. I'd like to welcome you all to the first of the 2025 speaker presentations set up by the Minnesota Lyme Association and the Lyme Association of Greater Kansas City. We will be coming together the third Tuesday of each month at 6:30, except for April when it'll be the second Tuesday. Judy Campbell and Ann Muir and I started talking last year and wanted to merge our two groups to bring speakers to the greater group with the hope of spreading more education and awareness. And we're so glad that you're here. We're thrilled to have a great lineup of excellent practitioners and educators willing to volunteer their time to present on various topics. And so far, we've booked January through June, and we're working on July through the end of the year. As you already know from us hitting record, we'll be recording these sessions and posting them on both our website and the Minnesota Lyme website and the Kansas City. And I believe Dr. Arrieta will also be posting it on her website as well. If you'd like to sign up for emails about these presentations and support groups, you can go to the respective websites. In addition, both groups have, monthly support groups. And I'd like to take a minute and go over a few housekeeping pointers. Please keep yourself muted at all times unless you're asking a question at the end, so there isn't a lot of interference with the speaker. And our speaker will answer as many questions as possible at the end as time permits. And we ask that your questions focus on today's topic and not general medical questions. We also wanted to share a disclaimer that the information and opinions shared today may not represent official views of Minnesota Lyme and Kansas City. And the webinar is not to be a substitute for personalized medical care. And please discuss anything you learned today with your personal doctor before starting any treatment. Today's speaker is Dr. Soleil Arrieta, a medical doctor and board certified physician with over a decade in functional medicine, integrative medicine, and family medicine. She runs Soleil Integrative in Winona, Minnesota, and works to help patients overcome complex chronic illnesses, including tick-borne illness, mold toxicity, chronic fatigue, and many other illnesses. She will be speaking to us tonight about SOT, a promising new Lyme treatment, as discussed at the fall 2024 ILADS conference. And again, we'd like to thank you all for being here and thank Dr. Arrieta so much for presenting tonight. And Dr. Arrieta, you can take it away.
Awesome.
Thanks.
Thank you so much, Britt. Thank you guys for having me. I'm super excited. So yeah, I'm Dr. Soleil Arrieta, and today we're talking about Q-REstrain. Q-REstrain is the new name for SOT. So a lot of people might have heard SOT over the last couple of years, but because it was presented at ILADS, maybe definitely more in the last couple of months. So wanted to give an introduction of what is SOT, how it can be utilized for Lyme and other co-infections, including viral illnesses, and wanted to introduce the fact that it is now renamed into Q-REstrain. So I'm going to go in between both of those, SOT and Q-REstrain, so you hopefully get the understanding that they're both basically the same thing. But if other clinics that you are around call it Q-REstrain, you have the understanding that you kind of know the 101 about the treatment. So yeah, so let's get started. Let's see. Alrighty. What is SOT? SOT stands for Supportive Oligonucleotide Therapy, and that is a mouthful, and I'll talk a little bit more in the upcoming slides about what that means. But this therapy is a specific single-stranded small interfering RNA, sorry, that says SNA, but that should be an RNA, that complements and hooks up to a very specific gene of interest. And what that means is as the pathogen, whether it's a bacteria, it's the spirochete, the viruses, as it goes through its replication process, the DNA turns into mRNA, and that is where this new therapy attacks. So it's really interesting. But that way we can go specifically after these microorganisms at a very specific targeted level. It actually silences that specific gene. And you might have heard gene silencing. So I want to let you know it actually turns off that gene and makes it so that the pathogen or that cell, if you want, I'm just going to start using Lyme. Lyme cannot continue to replicate, it dies, and it's a great thing to really decrease your load, right? I will say it is not gene therapy. So gene therapy changes the genes. This connects to it and silences it and turns it off. And another way, it is antisense. And I bring that up just because there's a lot of labs and studies out there that talks about antisense therapy, and it's basically the exact same thing. So SOT now in your head can also mean antisense, and we're going to talk about what that also entails. So we're going to get to the nitty gritty. What is a nucleotide? A nucleotide is these molecules. On the right-hand side, you see all of the breakdown products that form the backbone of both DNA and RNA. The difference is on the bottom. On the DNA side, you're going to have that purple one. That's the thymine. On the left, it's actually uracil. And so that's the difference. So an oligonucleotide, oligo meaning few or small, is actually a small chain or short chain of all of these little nucleotides. And so sometimes it's 15, sometimes it's 50 nucleotides all chained together. So if we do if we start thinking about the history of oligonucleotide therapy, we start seeing that it's been studied since the 1990s, and a lot of those studies actually label it antisense oligonucleotide therapy, and it's been utilized for various illnesses, diseases, but cancer readily in the last few decades. But the first antisense oligonucleotide therapy was FDA approved back in 1998, and that was approved for cytomegalovirus retinitis. So it was actually injected directly into the eye. So that's nice and fun. We've come a long way since then. Up on the top, we have an image of the DNA in the nucleus all the way on the left-hand side, right, in the yellow nucleus. As it starts to break away, it's starting to try and replicate itself, and from the mRNA, it will then make the proteins all the way on the right-hand side, which then continue to allow this disease or illness to replicate, cause damage, cause symptoms, etc. So the SOT is specifically tailored to this individual portion, which, if we think about it, it is more like a lock and key mechanism. So as we come out of the cell, the mRNA is this blue strand, right? This single strand, and that could be considered the lock, right? That's the specific section of DNA that controls important functions for either the cancer cell or Lyme cell or EBV mono pathogen. And it is stopped from continuing this process of making the proteins and then replicating because the antisense, also known as SOT, right, coming in from the top in that red or orange color, comes in and creates a key to that lock, right? And now they are bound together, and it blocks the function and blocks these cells' ability to replicate. And therefore, it actually kills the cell, pathogen, cancer, and it can no longer continue to thrive and replicate. So it's really cool. So it comes in here and it blocks it. And as you can see, is not actually affecting the genes. It's not affecting the DNA, but it is going kind of the step in between. I'm going to continue explaining this process with different imaging and different wording, just because we kind of learn in different ways. So on the top is kind of the normal way, right, that the DNA is then transcribed into RNA, and then it's translated into those proteins, which then cause those issues with the disease, the symptoms, replication, etc. On the bottom, we're stopping this process right in the middle with this purple antisense or SOT drug that is now also known as Q-REstrain. So it comes in here, that lock and key that we just kind of talked about, and it stops it from translating. So now on this bottom right, you see that there's no disease-associated proteins that are produced, and the body is able to degrade that RNA and get rid of it. It dies, it stops replicating. There we go, we stop that process. So just another way, right? Third time's the charm. Works by shutting down this gene replication. And again, there's a couple of different targets, whether we've been using this for cancer for, like I said, a couple of decades. And recently, it has now been used for a number of viruses and Lyme and co-infections. And it limits the next life cycle, it limits the proliferation, the replication, and then kills that cell as well. Currently, we have one study that has been put out. So this study was published in 2022 in Infectious Disease Reports. These physicians and researchers are from RGCC out in Greece, and there's a lab in Switzerland and all of that. But they got together because as they're trying to expand this SOT or Q-REstrain therapy into different tick-borne illnesses instead of just cancer, they wanted to do some preliminary studies and preliminary results and see kind of, does this actually work? Can we get evidence of it? And how many times do we actually need to treat for these? So on the bottom, I kind of blew up this sentence, but it says for Lyme disease, 1 or 2 SOTs therapies can lead to statistically significant decrease in DNA copies. Viruses would take 2 to 3, but again, you're still achieving that statistically significant reduction, which is pretty awesome to see. Right now, this is the only one out there. We have a couple of other studies about SOT in general, and obviously Lyme and co-infections, but as we continue to utilize this and we have more case studies, I think we're then able to gather the patient reports, and the research is continuing to be done in Europe. So hopefully we'll have continuous studies in the future. So which infections can SOT or Q-REstrain be given for? This is currently the available Lyme and co-infection all listed out. And so the Borrelia species are all the way on the left-hand side. Then you have a few Bartonella, then you have the Babesia, and then you have 3 others, basically Anaplasma, Rickettsia, and Ehrlichia. So it's fairly extensive, right? So they have already started this, and as they continue to find more primers, they're going to be able to add more species to the list, is the hope. They also have a list of viruses that SOT can be given for. So at the top, you have HSV, and going down to CMV, right, which we know was the first FDA-approved SOT for that cytomegalovirus retinitis. EBV right in the middle, also known as mono, that contributes a lot to some of our patients with their chronic fatigue, et cetera, as well as hepatitis B and C on the bottom, and even HIV. Okay, so some of the questions is, or would be, this is such a new therapy, but it's been utilized for so much longer in Europe. Is this currently FDA approved? And the answer is no, but the answer is also more interesting, I think, because SOT utilizes autologous, or I'm so sorry, my mispronunciation, but I'm just going to skip that word tonight. But materials basically from your own blood. So because they obtain it from the patient's blood, and because it's Lyme or viral DNA, they actually cannot be FDA approved. So therefore, these SOT or Q-REstrain or antisense therapy, if we're all lumping them all together, they're actually considered advanced therapy medicinal products. Similar therapies that would fall under this umbrella would be gene therapies, right? Stem cells, somatic cell therapies, tissue engineered products, etc. If we think about it that way, we actually utilize a lot of these therapies in different fields of medicine, even though they too are not FDA approved because they can't be for other reasons, right? For other specific reasons. But I will, in the EU, so in Europe, these products are actually under a little bit more strict regulation and medicinal products and European commissions and all that. So I put that on the bottom as well. So it's not like it's the Wild West out here, right? We're not just doing something all willy-nilly. So pros and cons of SOT. Why would I want to do this? Why would this be better, let's say, than antibiotics or herbal therapies? And especially because it's not FDA approved, is there any benefit, right? The pros of SOT, because it's such a highly specific targeted treatment, it is going exactly after that little gene sequence that it has been made for, right? So if you get a SOT or Q-REstrain therapy specifically for your, let's say, Borrelia miyamotoi, right? And you have one specific one, it is only going after that. That way we know it is, like I said, very targeted, very specific, but it is also not causing issues to the other cells around it. It's not disrupting the microbiome like antibiotics might. What's interesting is that in patient reports, they report less herxing with SOT or Q-REstrain, but not that there's none, but that it's a little less. And I think we have to do a little bit more research into that, into maybe explaining why. Maybe because it's so targeted, it's kind of like going in like a laser, right? Instead of dropping a bomb. And we're not creating a lot more of the side effects or inflammation that other treatments might. Or is it because we are stopping other therapies before we give SOT for a couple of weeks, and we really nail down kind of detox and preventing hurt? So there's definitely a couple of questions in there why patients are not experiencing as much herxing, but I'll take it, right? If this is a more targeted approach and you have the possibility of less herxing, sounds pretty good to me, right? Some patients might turn to SOT when all other therapies have failed, right? Let's say you've been treating chronic Lyme for a couple of years and you've done all of the protocols, you've done all the herbs, you've done all the IV antibiotics, you've done all the rounds, you've done cycling on and off, and nothing is working. This might be the treatment or the therapy for you. I would also, as we continue to talk about SOT, consider thinking about this therapy as maybe not the last resort, and you might get more bang for your buck if we move it up in the list, right? So SOT is, on one hand, pretty costly for a single therapy, but if it is so specific and it helps to kind of eradicate this chronic infection that you've had for so long, in theory, you could save money in the long run if you've been spending so much money, right? Treating everything else, going through like ozone and vitamin C and hyperbaric, and right, all of our time and money, and we're still not there. That's how you might save money, by paying a little bit more for each individual treatment at the beginning. So it might work when antimicrobials in the past had not worked. It's also much longer lasting. So one SOT therapy or Q-REstrain lasts in the body, and it's working 24 hours a day, 7 days a week for up to 6 months, just with one therapy. So it's pretty good. With a targeted approach, though, with this SOT, we're not necessarily forgetting the co-infection. So at the same time, you can still utilize those other treatments for your other co-infections. So if I go in and I'm treating my miyamotoi with SOT, but I don't want to forget my Bartonella, I can still take other options as well, but I don't necessarily maybe have to have such a broad reaching or umbrella treatment, because this one's being targeted specifically. And then I can add maybe 2 or 3 for these other things, right? So some possibilities, and it really depends on, obviously, the infections we're dealing with, how you handle things, but your specific treatment plan with your provider or physician. Cons is that because it is such a specific therapy, typically you need a SOT treatment for each individual infection. Now, this one has an asterisk, and the reason is because if I were to treat my Miyamotoi, right, with my SOT, in theory, everything else should stay the same if I'm not treating it, right? What we have seen, though, with case reports and also lab results is if you target one, sometimes the rest also get better. So these labs continue to decrease, my symptoms continue to decrease, and we recheck a tick panel 6 months after we gave you your first SOT, and now all of a sudden all 3 of my co-infections have gone down, but I only did 1 treatment, right? So in, I guess the way that you think about it is that I might get the results and I see that I have 3 co-infections and I worry that, oh my gosh, these each need an SOT, but it could be that, hey, I target the biggest one, my highest load, the one that's giving me the most symptoms, the one that's either positive on PCR instead of just antibodies, et cetera, right? There's lots of ways to consider your priority list and which way to treat. But as your immune system improves, as the whole environment of your body improves, right? As your immune system turns on and maybe gets a little bit stronger with just 1 SOT, it could, in theory, take care of others. So I don't want to necessarily say you have to have every single SOT lined up with every single infection, right? If that makes sense. There is also the flip side of that is sometimes 1 SOT therapy for 1 specific bug is not enough. So we've had patients, or I've talked to other providers and seen their case reports that the SOT that they were first originally given did decrease their load, but not enough that they would be considered negative or out of the woods. So they waited a bit, maybe they did another SOT, maybe they decided to go back to antibiotics, etc. But then they come back around and said, okay, now it's time for my second one. So sometimes SOT needs to be given more than once to be fully effective. Also cons, if you considering how much this plays into your list, it is not FDA approved, and so therefore it is not covered by insurance, right? And so it kind of comes back to, do we have money for this? And we're going to talk about that at the end of like cost and what is it all, et cetera, because there's a couple of different thoughts that go into that. Okay. This is a list of all the different SOT primers just for Borrelia burgdorferi. So this is not a therapy that RGCC just has waiting on their shelf, and then they're just going to pick one out and send it to you. When you send them blood, they are doing this significant analysis, right? And picking the one out of this entire list, let's say, because you order that SOT for Borrelia burgdorferi, and they're finding the one that fits yours. So that is how specific it is. That is how kind of nailed in genetically it is, right? So some people think, oh, it's just 1 for 1, and if it treats me, it should treat you, right? But look at this entire list of primers just for 1 species, right? And how many species there are. So there's a lot of work, right? And a lot of numbers and a lot of letters on this page. So that is why we kind of send the blood off to that lab. They do their magic, and it kind of makes me cross-eyed when I look at these pages, right, of numbers and letters. And then they send it right back to us, giving us that specific targeted therapy. So RGCC, this is a company that launched in 2004, and this doctor is a genetics pioneer, and he wanted to have the use of basically the antisense oligonucleotide therapy / SOT, which is now this Q-REstrain, effectively treating cancer for personalized medicine, right? Getting right down to those patients' genes. So they launched about 2 decades ago. They currently have labs all over. The big one that we use, especially for these SOT and Q-REstrains, is located in Greece. So we take the blood, we send it to Greece. Greece does their fabulous work over here with this woman doing her, again, her magic mojo all geared up. And then she sends us back the vial with the SOT Q-REstrain. They originally, like I said, started in cancer, and most recently they have expanded into their tick-borne illness and viral list, which we went over in the future or in the beginning. Okay, so I'm now interested in this specific targeted SOT therapy. How do I do it? What do I need? How do I jump through all the hoops? First, you have to have a positive blood test that shows that you are positive for one of the infections that they are treating. And it has to be within the last 6 months. Excuse me. So there's a little caveat in there that says reputable lab. Most of the labs that Lyme literate providers or physicians are ordering from are going to totally pass muster, right? If you are getting a PCR or antibody test from Vibrant or Igenix or any of the big ones, right? I'm trying to think, and then of course all of the other labs kind of float out of my head. So any of those that we're using, even if you have a Western blot, most people do not, but if you do, that still qualifies. And as long as it's within 6 months, you can order an SOT. What RGCC wants to know is, does your lab result that is recent enough that it warrants an SOT therapy, does it basically match the list of the pathogens that they can make a therapy for? And as long as it matches and it's in most recent time, again, it's from a reputable lab, you send them the results and they say, yes, order the SOT, we're ready to go. So that is already kind of step 2, right? You've already discussed these results. You've already talked to Dr. Arrieta, and she said, listen, we have all these options, and this might be one that's really good for you. And you say, yes, I want to go for it. So the next step is, now we have to draw blood, but this time not to see what you're infected with, but to send to the lab in Greece so they can make that specific SOT for you. There is a little caveat that is 2 weeks before you have this blood drawn to be sent to this lab, they want you to stop all antimicrobials and certain therapies for at least 2 weeks before you draw. And the reason is, a lot of us are treating, right, to either kill or suppress these infections. If we kill or suppress them and we have lowered this load down, when we draw the blood to send it off, there's a higher chance that the RGCC finds nothing. And they go, listen, why are you wasting my time, right? And so they decided, it is their protocol that they say, stop all therapies, stop all herbals, anything that is killing or trying to suppress these infections, and allow your level to come up. So then when we draw it, we can actually get the genes necessary, the DNA necessary, and so we can get you your specific SOT, right? So you're off therapies and antimicrobials for about 2 weeks. You have your blood drawn. That is then shipped from the clinic to Greece, right? Depending on shipping time, it might take, I don't know, 5 days or something. I was going to say, hopefully not that long, but anyway, it's going to take a couple of days, right? To go from maybe rural Minnesota all the way over to Greece. When Greece has it, they take it, it takes them a couple of weeks to now make your targeted SOT or Q-REstrain therapy. They then ship it back. That can take, depending on where you live, how often the mail comes, etc., about 3 to 4 weeks. So let's say it's about 4 weeks later. 4 weeks after your blood draw to send over there, now you have SOT or Q-REstrain coming into the clinic, and now you're ready to actually get your IV infusion. This is another time that right before your IV infusion, they recommend stopping all therapies, antimicrobials, for 14 days prior to treatment. Again, so once you get that treatment, it starts working immediately, right? If we continue those antimicrobials and other therapies, we're kind of lowering that dose and killing, and then we've spent all this money and time making it this targeted therapy, but it looks around and there's nothing there, right? So that is why they want you to, again, take your foot off the gas a little bit, allow the infection to be there, so when SOT comes, it can actually start eradicating it for good, right? And it can't do that if it's being basically driven into the tissues or under biofilm, etc. So that is step 4. And then step 5 is you have now gone back to your clinic or infusion site and you have received the SOT infusion. And depending on all sorts of things, it can take a total of, let's say, 2 hours. But that includes pre-treatment, because you actually have to have pre-treatment before the SOT treatment. Make sure you get the SOT treatment. You usually have a couple of, a little bit of IV hydration afterwards as well. And then we keep you there to make sure that nothing weird happens, right? No crazy anaphylaxis, no allergic reaction, your immune system doesn't suddenly go off, etc. So that entire time could take about 2 hours, but it's pretty quick in the whole scheme of things. And now you can go home, right? Because now the SOT is in you and it starts working 24 hours a day, 7 days a week for the next 6 months. Okay, so now we're going to get a little into common questions or frequently asked questions. And some of them, let's start with, is it even effective, right? Like, so do actually people have good results, and what has it been showing? Now, granted, with Lyme disease, they say about 95% of cases had a positive clinical outcome. This is from that study that I brought up at the beginning, right, from 2022. So if you guys wanted to have more info of like where to find it on PubMed, definitely take a picture of the screen or write down some of those PMCID numbers, etc. But in Lyme disease, approximately 95% of cases had a positive clinical outcome, which is pretty phenomenal, right? Those are pretty good results. And in virus-infected patients, whether that's CMV or HSV or EBV mono, the positive clinical outcome was about 91%. All righty, everyone take their picture? Okay, good. So I got tired of looking for DNA pictures on Google. So then I just started putting in pictures of my staff and I in clinic. And so you're going to see a couple of staff pictures in here. But common questions. Who can't do this? Who is this contraindicated for? So if you are currently pregnant or breastfeeding, it's a no-go. We actually want you to be 6 months out from breastfeeding or pregnant if you decide not to breastfeed to even consider. If you've had a recent blood transfusion, and that's about 4 months, okay? And then children under the age of 5 for anything like viral or Lyme. And again, it said it should be viral or Lyme, not of Lyme, but either one of those panels, right, that is newer that we are interested in, the child has to be older than 5. What are the possible adverse reactions? So a lot of these tend to be those hercs, right, that we talked about. Headaches, a little bit more fatigue, a little bit more flu-like symptoms, herxing in general. And you could flare co-infections if you are targeting a specific one, right? You're targeting that Miyamotoi, and then your Bartonella all of a sudden wants to flare, right? That can happen with other therapies as well. So we kind of plan ahead, and we want to make sure we decrease these chances as much as possible. So that is Taz. He's our clinic dog. So if you ever come to Soleil Integrative, you will meet him, and you might actually hear him. So I apologize. Oh, how many SOTs do I need? Okay. So each SOT, because it's targeting that specific region of a gene, theoretically, if you have multiple infections, you would need multiple SOTs, right? One for each, right? One for one. However, like we were talking about, the benefit of one actually might improve everything. And so we have seen that patient symptoms and labs have improved without treating a specific bug or individual species. However, we always put a little caveat, results may vary, right? Not everyone is so lucky. Okay, the pre-medications we kind of talked about. There's only one that is mandatory from RGCC. It's a small dose of dexamethasone. This is used to actually kind of for the vasculature, right? We want the veins to be kind of like nice and like tighter and not as leaky. And so when you put in the SOT right after, it's going directly where it needs to go and it's not leaking out everywhere and you're not losing, right, your treatment that you just spent all this time and money on. So that's a little dexamethasone. Optional, the famotidine, which is an H2 blocker, and acetaminophen, which is the generic form of Tylenol, can help to decrease any chance of that immune response that you might get from receiving the SOT therapy, right? A little bit of headaches, nausea, vomiting, diarrhea. The famotidine can be taken orally at home 6 hours before you have your scheduled IV infusion. Or if you want, I think you can also give it about 30 minutes IV before your SOT. But again, have we planned that in? Do you just say, I'm going to take it the night before, etc.? But and then some people skip it altogether because they've never had issues and, you know, they're one of, again, they don't need that extra medications. How many SOTs or Q-REstrains can I get? I have 12 infections and co-infections and viral loads and I just want to pound this out. What can I do? So there's actually a maximum of 9 Q-REstrain treatments in a 12-month period. So you can get individual ones, right? My Miyamotoi and my Bartonella, and then I decided to do EBV last, etc. So let's say I've already paid for and ordered 3. They have to be at least 7 days apart. Now, that is kind of pushing it because if you can imagine, you just got this very targeted therapy, you could HERX. So if I wanted to give you a second treatment for something totally different in 7 days, you might not feel up to it, but you could, right? In theory, do it as quickly as 7 days later. Now, let's say I did my Bartonella, but it helped only it really brought down the numbers, but it's still positive, and I want to do the exact same Bartonella again. That one has to be 3 months apart for that specific targeted, and you have to show another lab result. So let's say I get another vibrant tick-borne panel, and it has to show that it's still present, and then they go, oh, perfect, you do in fact need another one. So that's RGCC kind of doing their homework, right? Making sure that they're not just making SOTs and just giving them out willy-nilly. So for that Bartonella, you can get a max of 4, right, in 12 months because you can get them every 3 months. The hope is that you don't need 4, right? But how close together can I get them? And then that brings us back to a minimum of 7 days, but you can never, ever get the same, or you cannot get more than one SOT on the same day. And you should not have more than another therapy on the day that you get SOT.
This is Minnesota Lyme, that Dr. Arrieta.
Hey,
But
Joan.
I can't hear her.
Joan, can you mute yourself? We're hearing you. Thank you. Go ahead, Dr. Arrieta.
Yeah, all righty. So minimum of 7 days. This is, and just to tell you what this picture of, this is me at the top of Kilimanjaro. I climbed that in 2023. So yeah, 18 months ago or something like that. But I kind of like to tell my patients about what I'm doing because I myself have a number of these co-infections and Lyme and viruses, and I treat myself with all of these other modalities I'm talking about, but it kind of just says, hey, I can be a patient and a provider and climb crazy mountains at the same time. But as you will see, I'm obviously wearing a knee brace because the Lyme likes to hide in my knees. So, okay, can I get therapies on the same day as SOT? Absolutely not, right? Again, we are spending a lot of time and money on this very specific targeted treatment. Do not waste it by trying to add on other modalities at the same time. Reschedule that ozone for 1 to 2 weeks after, right? So no other therapies on the same day. And then this is just to remind you, it continues working for 24/7 for up to 6 months. Okay, what needs to be avoided? So certain therapies, right? Antimicrobials, hyperbaric oxygen therapy, ozone, IV vitamin C, all of those other modalities, and there's more that are trying to either kill or, basically suppress these tick-borne illness or viruses, need to be stopped 14 days prior to your blood draw, right, that we're sending off to Greece, and then again for 14 days prior to your SOT transfusion, just to make sure you're getting the best results, the highest number, and the most targeted therapy. But you're definitely going to need to talk to your physician or provider about looking at your treatment plan and which ones need to be stopped and started or can continue, because not everything has to be stopped. But I went ahead and stopped my Cowden, and I stopped my antibiotics, and I stopped my ivermectin or whatever else that I'm taking. When can I restart them? After your SOT, you can restart all of those antimicrobial therapies 7 days after. Some people choose to wait a little bit longer, but the fastest is 7 days, right? Give the first 7 days to this Q-REstrain, do its job, right? You might hurt a little bit, give yourself some breathing room, and then you can restart your antimicrobials. There is a little caveat too that RGCC actually recommends that you can restart biofilm busters immediately. However, my thought process on that is because biofilm or biofilm busters are releasing more, it could possibly expose you to more herxing, right? Because now you're releasing all this and you've just had this massive transfusion of SOT, which includes about 500 million to 1 billion copies, right, of this specific gene sequence. So they've all been transferred in. They're all around your body. And if you start biofilm busters immediately, in my head, you might hurt. So when I do mine, I'm probably going to hold off on my biofilm busters. But RGCC says you can absolutely do that because you are going to basically open up and release more of the pathogens or targets that they're looking for. So this is October. So I'm going to look at the picture real quick. So this is me this recent October 2024. I signed up and decided I was going to run the Chicago Marathon. I would like to remind you of my knees and the fact that I'm not a runner. So on this day, I did not make a good patient, but by halfway, I was totally out and I decided to listen to myself. So then I did. So, okay. Which of my supplements or nutraceuticals or other things can I continue? Because they're not killing anything, right? They're not antimicrobials, and because it can actually help prevent this herx that might be coming with this SOT or Q-REstrain, it is recommended to actually continue any detox support. So are we taking liposomal glutathione or milk thistle or toxes or ionic foot baths or binders, etc.? They say absolutely keep taking those. They also say you can continue with routine supplements, right? My vitamin D3 with K2 or other things. So anything that is not suppressing these pathogens and not trying to kill them, they said it will not interfere with your SOT. Next question would be, how soon or when do I next check on how well this worked? So they recommend getting the exact same lab, right, repeated about 4 to 6 months after your Q-REstrain or SOT to evaluate how well that treatment worked for you. Give it enough time, right, because the Q-REstrain works for up to 6 months. But if you're kind of chomping on the bit and you're like, listen, I want to know, do I need to order another one real quick because I can do it in 3 months, or do I need to jump from this one to this other co-infection, etc.? You can definitely test earlier. but they recommend sticking with the same. So if you were positive on your IGenics, get another IGenics. If you were positive on your Vibrant, get another Vibrant, just because it's easier, I think, to compare apples to apples that way instead of switching labs. And that is Taz enjoying the Mississippi River. So I'm super biased, but I think he's super cute. And that is a current clinic picture that we have there. So that's Karen Verkota. If you guys, I took over her clinic down here in Winona, and that's our staff, and that's me with Taz and all that good stuff. So we have an old clinic picture and a new clinic picture, and that is me. So my contact information is there, but I'd love to open it up and answer any questions that I was not able to answer during the presentation.
Krista, do you want to ask your question, or would you like me to read it? We have a couple from Styx, but I think she jumped off. So
Okay.
Krista's question is, when there are multiple infections, how do you choose which organism to target first? How do you decrease the chance of a flare or other co-infections? Oops, it jumped down. Especially since the SOT treatment lasts for 6 months and you're stuck, i.e. there's no way to pull back on the treatment.
Right. Okay. So there's a couple of thoughts that some people, when we have, let's say, your test results back of your tick-borne panel, some people say, listen, this one has the highest level on IgM, which is it's active, and it's the highest level, which means it's going to give us the biggest bang for our buck. That is how some people, right, will say, I'm going to go for that one just based on numbers and etc. Other people say, I take the numbers into consideration, but I also want to know symptomatically, what are your biggest complaints? Because if you're having more Bartonella symptoms and that's a bigger drain on you than, let's say, your Lyme symptoms, then do you want to start there, etc. There is some thought that some of these individual infections might be more difficult to treat or might require a little bit more. And those, I'm going to say, are going to be more your viruses. And so they typically recommend adding those like third, fourth, that kind of thing, kind of depending on how many we're dealing with. Because if we are hoping that my big one is Lyme, and that's my highest on my number, and that's the one I want to go for because that's got right. It's just bam, bam, bam. Of course, that's my number one priority. I'm going to treat that with the SOT, and I'm hoping that in the meantime, even though I'm treating specifically Lyme, my other numbers are improving. And so by the time I get to my EBV or my CMV as my third or fourth treatment, I might not need the 2 to 3 treatments that they noted that you might need on that study, right? Because I've already lessened some of that. So there's a couple of ways to think about it. And that's where you talk to your provider about it, about what are my priorities? How should I go about this? How have I even handled previous treatments? Do I need to go really slow and be very careful, etc.?
I guess just one step back to some of the questions that we're getting is because some of the people logged in tonight are from the Kansas City area, and this is a new treatment. Like now we know that you're in our general area of southern Minnesota and you offer this treatment, but do you know if there's quite a few practitioners that have started doing this? Or do you know?
So definitely, yeah, so definitely more now than there have been. And the way I would go about finding a practitioner is actually reaching out to RGCC, that international lab. And so if you Google RGCC International, they have, their website is readily kind of right there. But if you contact their, I'd say North American, there's a branch over here in Denver, Colorado. We don't have a lab. I think they're working on it, but anyway, they do have an office. And if you email them, they will provide, because they have a whole list of providers that have gone through training with RGCC, and you have to be certified, gone through their training to even have this treatment available in your clinic. So that's the way I would go about finding a practitioner near me that can offer this therapy.
Okay. And you learned about it at ILADS or heard more about it at ILADS, but are you trained to do it now?
Yes.
Okay. Okay. How much is one treatment for one organism?
Yes. Okay, great. Cost. Now, the cost is going, I think it is kind of depending on where you're at, because most clinics are actually packaging this together as an entire infusion therapy. So the test is included, the lab processing fee is included, the supplies are right, and they're kind of just saying, hey, listen, for this set price, we will do all of these things all together. I'm trying to keep my price, and I have not priced it out, but I'm going to try and keep mine about $3,000 per treatment. Now, the average is up to 5,000, and then there are some clinics in Florida that are offering it for 7,000. So it really depends on where you're located, right? If you're in Manhattan, New York, your prices are probably going to be a lot more significant than rural Minnesota. But that's a little bit more of, you're kind of in a high cost of living, et cetera. But the prices, I know we are trying to keep them as low as possible where we are located in Minnesota and Wisconsin. And that is what the clinics in this area are pricing, around 3,000. And that is just to keep it more affordable for us. So if we do need that second therapy, or we do need, more than one, et cetera.
Okay. Someone made the comment that also the clinic up in Alexandria is offering SOT. So that's
Awesome.
good to know.
Mm-hmm.
And someone asked if there is a chance of autoimmune reaction with DNA therapy.
I think it depends on the individual. I will say that from the readings or the case reports and the stuff that they're putting out there on individuals that might be more sensitive than others, you talk to your practitioner and your physician, you kind of develop a game plan for, hey, when I do this, I always flare, or this happens, etc. And then you have okay, before we actually give you this is what our pre-treatment plan is going to be, right? And so you might have a more extensive pre-treatment plan. You might talk to your provider about, can I do this in half dosing, right? So that is usually not recommended, but in theory you could. You could give half a dose and then 2 to 3 weeks later give the other half before it goes necessarily bad, right? Because it will still stay safe as long as it's kept cold enough. So there's lots of workarounds for them, but again, that's more of an individualized. Definitely talk to your practitioner about this and figure out a game plan. But I would not write you off saying you couldn't do this, but you might need, other caveats, right?
Okay. Is there a chance of getting Guillain-Barré syndrome from it?
We have not seen that.
Okay.
Yeah. So from the patients that are doing this, and I know definitely would recommend if this is brand new to patients, there are numerous YouTube videos from patients that even a few years ago when this was only being given over in Europe and Greece, that flew over there to get this. So a couple of years of, hey, this is what I did, this is how I reacted, this is how many I needed. So that I think is also a great wealth of knowledge on YouTube, especially from the patient standpoint.
Good. Does it cross the blood-brain barrier, and how well does it target bacteria and biofilm cyst and tissues or other common hiding places?
Yes. So it crosses the blood-brain barrier. It does not. So because it's a specific gene, right, sequencing that mRNA, that lock and key kind of thing, it needs to be basically out and replicating and proliferating, et cetera, which is why the RGCC says, hey, go ahead and jump on those biofilm busters immediately so you can release more. So they definitely want us to, depending on how aggressive you can be, actually bring them out of tissues and in hiding and treat with those biofilms for that specific reason.
Okay. And besides the medications that you talked about and supplements that you have to stop, beforehand? How about if you're on a lot of other medications, do you have to get off those meds before SOT, like for migraines, high blood pressure, heart medicines, etc.?
No. So anything that is targeting the specific pathogen that we're looking at and trying to treat are the only things. So if we're on diabetes medications, yeah, heart medications, we continue all of those because they're not affecting the Lyme or Bartonella or EBV, right?
Okay. And then, let me see if I understand this. Are the clinicians working with RGCC labs pooling their data on efficacy?
Yes, so that is my understanding. So I've just talked to some of the researchers and providers, and they definitely encourage to gather information to say, hey, every time you do this, I want you to kind of in your chart note 3 months after you give it, what are their symptoms? Have they improved? 6 months after, did you repeat that lab? What does it do? Right. And so we are actually gathering in real time more and more information. And I think the more clinics we can do that and the more patients get involved, definitely the more information and therefore studies and published reports we can get.
Okay. This hasn't been asked yet, but I guess this just popped up in my mind after that last question. Do you think with more time and cases that it would ever be covered by the FDA? Or is it not?
Well, because it's the it's basically the advanced medicinal product, or you know what I mean, whatever that is, like kind of like stem cell therapy. I don't think it can be FDA. I think the reason that this works so well is that it is so specific to you and your specific bug and the species of bug that you have. And because it's all from you and that information, they could never kind of trademark or make an umbrella saying, hey, this one treatment treats everyone's Lyme, because we know how difficult it is, right? And how everyone's Lyme is different. And my Lyme could be from this species and yours is from a different, et cetera. So that I think is the difference of FDA approves usually one, right, kind of group of molecules. This is the chemical, this is the drug, this is the pharmaceutical, and it treats X, Y, and Z, and that's it. And that's what we then approve when we get studies for. But because of just the nature of this therapy, I doubt FDA will ever say yes.
Okay. So. We have a new question. What if you cannot take dexamethasone?
That is a good question. So I'd probably run it by RGCC and just say, listen, if we're using it to help the SOT work a little bit better and not leak out. And so in theory, if we have any issues, we can say we cannot give you this medication because let's say you're deathly allergic to it or something, right? And so then we could say, let's take the chance, and I'm willing to do the Q-REstrain or SOT therapy without pre-medication. And RGC says, yes, do it, but we have no idea how you're going to respond or if it's going to work it out. You know what I mean? So that would be my thought.
Okay. And I'm not sure I'm going to pronounce this word correctly, but the next question is, does SOT work better than phage treatment for Lyme? A Franklin, Tennessee clinic now does phage, PHAGE.
Sure. So that is a good question that I do not have enough information or knowledge about to answer. So I have no idea.
Okay. Here's another question. I'm concerned about other co-infections flaring in someone whose immune system and body systems are extremely compromised. Could that be a reason to not get SOT treatment?
It could. In my head, though, is that okay, so we're worried about co-infections flaring, but that is when you would restart therapies for those co-infections, right? So I think you would still be covered. It's not like we're taking away everything forever. It's just a, hey, I really want to drop this laser approach for Lyme. And then 7 days later, I'm restarting all my Bartonella stuff. I'm restarting my stuff. So it doesn't give it enough time to kind of flare and double up and do all of those things. But we're also not trying to double hit it and which could in theory make you hurt more, right? So I don't think the 7 days after the SOT would be enough time, but again, you'd have to talk to your provider and physician and say, with me and my specifics and how I've reacted them back and how I respond to treatments, would I be a good candidate? Could I do this, or what's my workaround, or, you know, work one-on-one with them.
Okay. I think I captured all the questions. I kind of jumped around to try to group them. So if
Dr.
anyone else has
Soleil?
one.
Can I
There.
ask a question?
Absolutely.
Sorry, I thought it would be easier than me writing this out.
Yeah.
So Jonathan Otten here. I had to take off from the International Lyme Conference before the Sunday sessions where they discussed SOT. So
Mhm.
thanks for your presentation on this. It was excellent.
Yeah.
My question is that Apostolo study or whatever that you cited, I think that it showed the reduction in the gene copies for Borrelia or whatever. But
Yes.
has there been any published studies that actually show, or case series where it show clinical reduction in symptoms in a patient where, because was that part of that study at all?
No.
Okay.
Yeah. So they were really looking at the hard and fast, kind of like lab side of it.
Yeah.
The symptomatic, more subjective part of like, hey, I'm feeling so much better, are really coming from case reports from clinicians that are actually practicing this, and they are learning kind of on the go and saying, this one works better if you do it kind of in this priority, and if our patient's really sick, you have to pre-medicate this way, right, etc. The good news is that we do have a lot of anecdotal evidence that this is working really well for patients, but it's also not a panacea, right? This is not a cure-all, which I wish it would be, but there is always going to be patients that like, listen, it helped, but like it only helped me 10, 15%. And like, we didn't know until we tried, right? Which is unfortunate, because there's also on the flip side, patients that are like, I just did one and I feel 100% better, and now I'm back to running marathons. And I'm like, what? I want that one, right? But we can't choose. So yeah. So right now, unfortunately, I think it's all anecdotal case reports. But to my knowledge, with my recent research on Google and PubMed, nothing has been published. But I'm hoping as we collect and as our GCC asks for information back, that they will actively start, collecting everything and then pushing that out.
Cool. Thank you.
Yeah. Thanks so much for coming.
And Dr. Arrieta, how many patients have you treated with SOT so far?
So I'm going to be the first.
Oh.
So yeah, I'm super excited. I have I'm in close connection with the research providers at RGCC and a couple of providers that I met at ILEDS that have been doing this for about 1 to 2 years. And they're the ones that are really helping me kind of think about things and right. I've asked all those questions, like what is my priority list? And if I have 12, like which one do I choose first, et cetera. But because I have so many co-infections myself, I also say, listen, I'm going to put myself right on that front line, and I'll let you know kind of how I do and what I think, and was my hurts really that bad, and, et cetera. So hopefully you'll have more personal experience. But I just got certified RGCC last week. So it is brand new. So now I can start saying, yes, I know exactly what to do, but now I can actually give you these infusions, because it goes right hand in hand with the ozone that we're doing and the IV vitamin C, et cetera. So
do you know when you're going to be doing it?
I'm ordering the lab, like the kit. And so it kind of depends on, when it comes in, but not hard and fast dates yet, but yeah.
Okay, we just had a new question come in. Is dexamethasone dangerous?
No. So here's my little concern when I first heard about dexamethasone is, especially in the Lyme community, we are very wary, right, of steroids because it's immune suppressant, and we know that other things, when we suppress the immune system, can flare and weaken hurts and all that good stuff. But because of the dose and the quick kind of action that we are trying to do and the benefit for that SOT, they have not seen those flares or those immune counter response that we might get if you took like a course of prednisone, if you will.
Good.
I have a question too, if I can just ask it. And
Yeah.
and this is more about the testing. So let's say if somebody had a positive PCR for Borrelia and you draw the blood, you send it to the lab, they do an ultra super PCR that identifies all the components. So is there any benefit that, let's say you weren't an early adopter for different treatments, could this be sold or purchased separately just as a super test so that you may not know what you have co-infections or the load levels, or used for other diagnostic purposes without this specific treatment? Just the testing portion?
Sure. So I would then direct you to their partner, BioCentaur, I believe it is, and they have a panel, basically like a tick-borne panel and then a viral panel. Is that what you're wondering, just to see what you're positive for?
Yeah. So would this test be available in it? Would that be domestic and not have to go to Greece Center?
No, these would still go abroad. And so therefore, if we're paying to have the exact same test done, then I would say, hey, it's probably cheaper to go Vibrant or Igenix, or, you know what I mean? But they do have those available. So for patients that, let's say, their last Vibrant was 18 months ago, we need one within the 6 months, and they go, okay, well, go ahead and do that test, and then keep my blood that you've already ran the test on, and then take that and make the actual SOT from that. And so there's, in theory, a way to do that. But again, you'd have to combine it all through those labs over in Europe.
Okay. I guess to summarize my question, I haven't been around testing for a while, and there's other things that always go on in life that have to get taken care of too. So I was just wondering, from a testing standpoint, is their testing unique then, or would you be able to get that same level of specificity from one of your other labs that you're mentioning? With the whole list of every PCR that they showed up in a load, a load ratio.
Right. Anecdotally, from other providers that have done this a lot more, they say that the RGCC lab results are a lot more, I think, sensitive to especially PCR, because that's what we run into with other PCRs here, right? Is sometimes we just can't find it. And so they are, I think, comparative, getting better results, but that's why they will also take the antibody results from here, which sometimes are easier to get, right, than PCR. So they say, listen, we'll take whatever, but we have a little bit more robust PCR. I don't know if they have a better machine. I don't know if they have better advanced technology, you know what I mean? But the providers say that theirs are a little bit better.
Okay.
Yeah.
And that can't be necessarily a standalone. It's bundled in with the treatment.
No, if you want to get just their tick-borne panel, I think they're going to tell you to go to their other lab. I think it's called BioCentaur, but if you reach out to them, they're going to say, oh, that's our friends over at, wherever. And then they work closely together.
Okay, thanks. That's enough time for my question. Okay.
Okay, here's another new question. Is any lab company ever going to be able to do SOT inside of the US, or is the FDA always going to block a lab in America? Maybe RFK Jr. could be contacted to help. He's from New England and must know tons of people who've had Lyme. Well, I think you kind of alluded to that possibly in the Denver office that they might be working on something.
Yeah, so because there's been such an influx of physicians and providers in the US that have reach out in the last like 2 years even, gone through this training with RGCC, they said, wow, there's a lot of you guys, we need to open up a satellite. And so then they opened up basically clinical support in Denver. And I'm hoping that, I think if we continue to see this grow and more of our providers are doing this training or getting certified, then they will see that there is a need and a want, and they will actually move a lab here. But that's me keeping my fingers crossed. So yeah, was that the end question, was like, were they going to move a lab here? FDA approved. It's probably not going to happen just because of the way that SOT and Q-REstrain is, right? Like I said, you'd have to, it just falls under like stem cell therapy and somatic cell therapy. It's just, yeah.
Too personalized. Okay.
Yeah.
Yeah. Good. Well, I think we're caught up on questions unless someone else wants to unmute themselves and ask a question in person. All right. I think that might be the end of the questions.
I just want to say thank you very much, and thanks much, and good luck with your treatment. We'll be rooting for you.
Thank you so much, and thanks for coming. And I'm super excited about this. So thanks for coming and hearing more about it. But if you guys are definitely wanting to do more research or find other information, YouTube is fantastic. The two providers that I'm getting a lot of information from is Dr. Clayton Bell, Bell, and Dr. Peterson. And they have lots of YouTube videos. And then I love watching the patient videos because they tell you in real time, listen, this is how I'm feeling. This is what it did to me, etc. So YouTube is awesome. And then if you're looking for a practitioner, I would go directly to RGCC and say, can you email them? Because they're super quick on their response too. And just say, hey, I live in Kansas, or I live in, wherever. Can you give me a list of certified practitioners around me? So they will really kind of do that homework and legwork for you.
Good.
But thanks for having me.
Yeah, thank you so much for taking your time, and let us know how your results go, and we wish you
Yes,
success.
I'm keeping my fingers crossed.
Yeah.
So.
Good. Well, thanks so much, everybody, and we look forward to meeting all back here next month. And yeah, thanks so much. Stay warm, everybody.
Yeah, night.
Good night.
Thank
Bye-bye.
you.
Thanks.